working directly with 74 social enterprises that operate in more than 70 countries, as well as large multinational corporations, investors, and foundations. The organization aims to bring together a strong community to improve access to affordable and quality healthcare globally. Representing Duke is the Executive Director, Krishna Udayakumar. Before we proceed, a few housekeeping instructions. We will not take any questions during the presentation, but will open up the floor for questions after the presentation. Please feel free to use the console to type in your questions during the webinar, and I will raise the questions to our speaker after his presentations. If you have any further questions that are not answered by the end of the webinar, you can email us at membership@avpn.asia. Without further ado, I will now hand over the presentation to Krishna.
Great, thank you, Ashima, and thank you to AVPN for the opportunity to present our work today, and welcome to all of you that are on the line. I will take a few minutes this afternoon to tell you about our approach to scaling health innovations around the world and focus in on a couple of projects we've done over the last 2 years, which is to look at the healthcare investment landscape from both the investor lens as well as the innovator lens, and tell you a bit about our lessons learned in that process. And then I'll end by talking about how we're thinking about linking the grassroots innovation perspective with a health systems approach to see if we can make transformative impact in health and healthcare. So with that, I'm not sure if I'm able to drive. I am. So we'll start by setting a bit of context on why we do the work that we do, and that's really to address enduring health challenges all around the world. In the context of Asia, we know that there are rapidly developing economies. There continue to be significant disparities in cost, quality, access to health services and technologies. At the bottom of this page, you see something that we commonly refer to as the triple aims of healthcare. So how might we better improve the experience of care, improve the health of individuals and populations, and at the same time lower costs or create financial efficiencies? And this is really the structural challenges for almost every health system around the world, whether it's a low, middle, or high-income country. Some of you have probably been seeing some of the political conversations happening now in the U.S., where we're based, around what the future of health reform may look like. I'm in London this week, and it's quite similar sets of conversations around how to control cost and assure quality and access across the NHS in England. So I think many of our health systems are more similar than they are different. So we're really interested in figuring out what the key health challenges are, and we know that the health challenges are continuing to evolve with rapidly increasing rates of non-communicable diseases, aging of populations, and the recognition of the lack of both health infrastructure as well as health workforce. In order to address that, we started our organization 6 years ago with the understanding that there are many things that innovators or entrepreneurs are already doing all over the world. And if we were to better harness the innovation and entrepreneurship that's already happening, we may have at least a partial answer to how we fix health systems. So one of the things that we've done is try to study what's happening in healthcare around the world, especially in low resource settings, where we're starting to see many of the most transformative or creative solutions coming up. If you look at the top left side of this page, you'll see what is this blue box, which is really just a shipping container sitting by the side of the road next to a truck stop in sub-Saharan Africa. This is the work of an organization called North Star Alliance, and what they've been able to create is a low-cost model for creating a network of health clinics by leveraging shipping containers and using that to provide access to health services and technologies for migrant workers, including truck drivers, up and down the trucking corridors of sub-Saharan Africa, and in this very low-cost manner, but enabled by very sophisticated information technology, they're able to provide health counseling, primary care, as well as access to other specialty care. If you look at the bottom left of the screen, you'll see a group of doctors that are part of a call center based in Mexico City. An organization called Medical Home is working diligently through a joint venture with the largest telecommunications firm in Mexico to provide access to health advice to people who subscribe via their mobile phone plans. And they've now done more than 10 million phone calls and been able to answer questions more than 60% of the time without having to refer their clients to health facilities. And at the top right, you'll see a picture of one of the most famous innovative hospitals in the world, the Narayana Health flagship hospital in Bangalore, India, where they are creating incredible efficiencies in terms of producing high-quality, low-cost services, including open heart, very complex surgeries, which they're able to do at about 5% of the cost of what it might be in the U.S. So when we've studied these organizations as well as dozens of others, there are some clear secrets to success or critical success factors that come through. And this is what you see listed on this slide. So what we've learned from these organizations is, one, that it's really about the patient as a consumer and understanding what their behavior patterns are and their desires and being able to meet those. The second is using mobile phones as significant technology improvements that can be used disruptively to extend the reach of the health workforce. Third is to relook at what our health workforce actually looks like in terms of not relying overly on doctors and nurses as traditional health workers, but really extending that to community health workers, enabling patients themselves as well as their communities to be more engaged in their health. The fourth is to standardize, something that other industries have moved to much more aggressively than in healthcare, and trying to reduce variability and thus improving quality over time. And finally, thinking about asset-light models, so trying to avoid big capital expenses and expensive buildings, expensive people, expensive equipment, but thinking about how to take a light footprint, asset-light approach to improving health and healthcare. And we thought there was enough interesting work to be done in this space, and perhaps not enough being done in terms of scaling successful innovations, that 6 years ago we created an organization called Innovations in Healthcare, jointly founded by Duke University, McKinsey & Company, and the World Economic Forum, to do just this, to find the world's best innovators and find ways to scale and replicate their impact. We do this in 4 programmatic areas. The first is to try to source and curate the world's best network of healthcare innovators. Over 6 years, we've developed a network of 74 organizations that are operating in more than 70 countries around the world. And on the map on the top right, you'll see where our innovators are operating in the orange circles, and you'll see that Asia is very well represented in terms of where we're seeing the best innovation come. And across Asia, you'll see the biggest cluster of innovation coming out of South Asia. The second area we work in is really to try to understand what the scaling challenges are and to find ways to strengthen organizational capacity. We do that by running our own capacity building services. Over the last 5 years, we've run a global health enterprise accelerator program focused on 25 organizations operating in India and East Africa to try to scale impact and do it in a way that we learn what works and what doesn't work. We also leverage significant public and private sector networks to try to bring to bear resources with the organizations that need access to them. The third area we work in is to try to study what works and what doesn't work so that we're moving the field forward and building an evidence base that others can use. And fourth, we try to put all of this knowledge into practice by rolling up our sleeves and supporting the scaling and adaptation of innovations around the world. I'll make a plug at this point that we will soon be launching our next call for applications. Each year we select a new cohort of 8 to 12 organizations from around the world to enter our network. So for all of you that are on the line, we hope that you'll nominate yourselves if you're innovators that work in this space, or if you're investors or intermediaries, that you will refer to us the best organizations, the most promising that you work with, so that they can be part of I said, in two ways. First, I'll start with work we did in trying to understand the investor perspective and what they're doing in this space. So in 2015, we undertook a collaborative approach. You see a lot of logos on the bottom of all the organizations that were involved, and this was work that was supported by USAID that looked at what was happening in two particular locations, in India and in East Africa, particularly in Kenya, to try to support through investment the growth and scaling of global health or healthcare innovators. And in this work, we looked at several dozen organizations that were in this space through desk research, and also spoke directly with more than 30 healthcare investors and got first a sense of what their own goals were. And what you see represented here on this slide is at the top the organizations that were focused on India predominantly, on the bottoms those that were working predominantly in sub-Saharan Africa, and in the middle those that had a blend or a global approach. And what we found from this is that there was significant capital going into the growth stage and try to take some scaling risk. Less so in the seed stage of taking promising organizations that were still working on things like creating the right unit economics, getting the right customer behavior patterns, fixing supply and demand, and being ready to scale. And so we continue to see this type of gap both in terms of the stage of development as well as the ticket size that many investors are looking to in their deal flow. So what we took away from this were a few major themes. One is there's a significant need, but also an increasing appetite to invest in health and healthcare. Secondly, a greater need for organization of that supply and demand inefficiencies in this market. And third, that we were seeing too much investment being made based on what the capital needs were of the investors as opposed to what the enterprise needs were on the ground. We came away from this study quite optimistic. One, that there's significant demand, that not only is there rising demand with the growth of the middle class in many low and middle income countries as well as urbanization, but there's also increasing access to information and technology. And amongst not just the upper class, but middle class and even bottom of the pyramid, willingness and ability to pay for access to high quality or perceived value health services. Secondly, there's also a significant increase in the recognition that there's a role for the private sector in healthcare markets. In fact, just yesterday evening, I was at the public launch of a new report done by commissioned by the CDC group here in the UK and done by colleagues at the Imperial College London that looked at a framework for understanding the impact of the private sector in healthcare. So I think there's more and more work being done, not just to support the private sector, but also to understand its impact in supporting things like universal health coverage. And the third reason for optimism is there's significant growth in this industry. So double-digit growth both in India as well as East Africa, which isn't surprising given the need for health services in these regions. There were certainly some risks that we heard from many of the innovators we spoke with. The first was just a sector risk in that health systems are complex and that there's still a lack of consumer awareness, a pipeline of health workforce, fragmented, if any, quality standards. The second was the political environment in which health systems work in terms of the trust between the public and private sectors and unpredictable regulatory environments, and a risk of over-reliance on the public sector as a source of revenue for the private sector. The third thing we heard significantly and see in our own work are challenges with business models, and not just proving at a single unit, but how do you take a model to scale when we know that the majority of expenses in healthcare are for labor and people. So how do you actually find a model to scale workforce in many economies where that's already a shortage? And then the fourth was this issue of a mismatch between the capital available and the capital needed across the sector. What we came out of this with, and we can certainly reference you to our report for more details, is a recommendation for investors looking at health opportunities in low and middle income countries to think about this in two stages. The first is really to understand the market context of the enterprise or initiative in which you would like to have impact. And secondly, then really understand at the level of the enterprise what their current state of development is and what type of capital might be most useful. In terms of the first approach, this is a busy slide. I'll walk you through a bit of it. On the left-hand side, what we tried to do is look at different sectors within healthcare, everything from delivery to devices to pharmaceuticals and financing, mobile and tech, and logistics and distribution. And on the top, you see different populations that these types of solutions try to reach. Everything from rural bottom of the pyramid up to high-income urban populations. And across these, in the cells, you see where we picked up some particular market inefficiencies, whether it was information asymmetry or price sensitivity and lack of access or infrastructure. And you'll see significantly more market inefficiencies or market failures as you get to the bottom of the pyramid, low-income types of populations. Based on this, we think that there's an appropriate balanced approach of how best to deploy different types of capital. That on the right-hand side, looking at market returns serving high-income populations, we think there's a role for traditional capital. In the middle, where we're trying to reach peri-urban, middle to low-income types of populations, we think there's a great opportunity for impact investment to play in the space. And then on the left-hand side, where we're really trying to reach low-income, bottom of the pyramid, rural populations, it's unlikely that there are sustainable business models that don't rely over time on grants or philanthropy or charity. So we think that by a more balanced approach to the health sector, that we can help deploy capital more efficiently. Then secondly, we also recognize that there are significant stages of development for each of these health enterprises, and understanding through case studies what worked and what didn't work in scaled enterprises, we think is a good way to also take lessons. I've included one case study here that I'll touch on very briefly, and it's a case of Frugal, which is a social enterprise that's focused on using mobile technology to combat counterfeiting. And we know that this is a huge need because in emerging markets, almost a third of all medicines end up being counterfeit. And so their proprietary technology platform is something that pharmaceutical companies have used and is free to the end consumer and provides confidence and a check to ensure the reliability of these technologies. What you see in the timeline with the different colors are the evolution over 6 years or so of this organization, and everything from seed capital to impact investment to impact debt over multiple rounds. And this was really influenced by what scaling of this type of business looks like, which is different than many other types of healthcare businesses. I won't get into the details here, but would be happy to take any questions you might have, or again, much more detail available in the report on our website. Now, the second thing that we tried to do is to understand the same area, but from the lens of the entrepreneur or the innovator. So we undertook in 2016 a study that was supported by the Pfizer Foundation that spoke with and did workshops in India, Kenya, and Mexico, trying to get the entrepreneur perspective of what they're seeing and what their needs might be. We, as I said, think this is very important because efficient capital markets are very important to scale the most promising health enterprises. We know that others are also interested, whether they're investors trying to have impact or intermediaries trying to serve this market. A bit of context, and one of the reasons in the prior study and in this one that we looked not just at one geography but at multiple is that we believe there's significant lessons to be learned by evaluating approaches across different geographies, knowing that the context is different, but we think there are generalizable lessons to be learned, as well as particular lessons that can be shared and adapted Great, sorry, I think I lost my audio connection for just a second there. Hopefully you all can hear me again. So what we learned from doing this type of work was that there are different types of innovations we're seeing come about in each of these different geographies, as well as different limitations in the capital available, a very different role for the government based on the country or the region, which significantly alters the scaling pathway, as well as very different types of business support that are seen. And so the lessons that we hoped that others would be able to take away from doing this work were that, and this is some of the data that we picked up, and these were 33 different health entrepreneurs that are working in these geographies that we looked at, and you can see between those operating in India, Latin America, or East Africa, what their general capital needs were, as well as the type of capital. And you can see in India, for example, there was both a relatively small as well as mid-sized need for capital in terms of grants as well as equity. And it looks a little different in East Africa, where there's much more reliance on grants and earlier stage equity needs. So what we saw was that the capital type that's being deployed creates its own particular benefits as well as challenges. Where we saw grant funding being deployed, there was a perception, at least from the entrepreneur perspective, that the donor interest can change frequently and lead to misalignment over time, as well as limited availability of grant or non-dilutive capital. In looking at equity and debt investments, there was a sense from the innovators that especially global investors didn't have enough local knowledge and familiarity to understand the risk profile and the investment thesis. There were also very different financial and business standards across different investors. The debt that was available is oftentimes at high interest rates. So we continue to see a need for below market debt as a key aspect of impact investing. And in these markets, the exits are oftentimes few and far between, so there's very little confidence that's gained from understanding how exits might work. In relying on the public sector for revenue, this was seen as slow. Many other private sector funders were leery of developing government partnerships. There was a risk in turnover of governments and often difficult to access. And across all of these, we saw that there was still difficulties in connecting across funding partners, as well as aligning capital needs. The implications we saw from this for funders themselves is to understand these operating environments further, to assess the stage of development, to try to create co-investment platforms, especially linking global to local investors to bring the best of both of those perspectives, and then consider innovative financing mechanisms. And we thought it was an important perspective that one of our innovators provided, saying that they oftentimes had to build not just their organization, but the entire ecosystem around it to try to be successful. For innovators, some of the lessons we took away from this are to really understand not just their organization, but their local market, to be able to have that educated conversation with investors, to have very clear strategy matched to financing needs, to have very clear metrics and KPIs, rely on networks to get access to seasoned entrepreneurs and other advisors. And we thought it was important to include financial and legal expertise in that type of advice that they were seeking. So those are two different perspectives, but we think valuable and very complementary lessons that we took away from it and incorporated into our own work. The third area I'll talk about briefly today before moving on to our discussion is to tell you a bit about our work. I've told you about some of the grassroots scaling and strengthening that we do, but what we've started to recognize is that any of these individual innovators can certainly have significant impact where they work, but it's very hard to move the needle at a health system perspective if we're not thinking about broader perspectives of scaling and adaptation. And I want to tell you just a couple of stories to get us started. If you take a picture, look at the picture on the top left of the screen. This is the work of an organization that's called Basic Needs that works in mental health and community development. with a proven model operating in 12 countries across Asia and Africa. And they've shown that you can take an efficient approach to linking community-based mental health services to the people who need them, to empower people with mental illness through self-help groups, to provide vocational training and reintegrate them into society, and to do it all under an evaluation framework. We were able to work with this organization through the support of the Robert Wood Johnson Foundation and actually create a business plan and implementation partnership looking at the U.S. market. And now they've launched a demonstration project in Detroit, Michigan last year. The picture on the bottom left builds from a story I told you earlier about Narayana Health, the hospital in Bangalore that's doing open heart surgery for as low as $2,000 US. They, to try to prove that this was not a uniquely Indian phenomenon, as well as to access other markets, created a joint venture with Ascension Health, the largest nonprofit health system in the US, to create something called Health City Cayman Islands. And what you see there is the opening of the facility. And what they will eventually grow is up to a 2,000-bed hospital that will serve the Caribbean as well as the U.S. markets and be able to offer U.S. quality outcomes for anywhere from a third to a half the price point. On the top right, you see a picture from an organization called Sala Uno Salud, which is based in Mexico. They took the lessons from Arvind Eye Care and L.V. Prasad Eye Institute in India, where they're able to operate a focused factory approach to do very high quality, very low cost cataract surgery, and brought it to Mexico to prove that this was a set of principles and philosophy that could work everywhere. And then finally, Consejo Sano, or Healthy Advice, is an organization in the U.S. that took the model of medical home, which I told you about in Mexico, and brought it to the U.S. to serve Spanish-speaking individuals, and they've recently raised almost $5 million in capital to expand further. So we're starting to see that one of the ways that scaling can be done is really for local organizations or for global partners to take on the task of adapting and moving these organizations to different contexts. And a lot of this is done through the lens of frugal innovation. So how might we do more for less for many? And to look at this, we undertook a study jointly with colleagues at Imperial College London, looked at 5 different models, including 3 that I described on the last page, of models of frugal innovation. And the key themes we saw across these were, 1, the way to lower costs is to change the settings of care and the providers of care. So move work that might traditionally be done in a hospital out to the clinic, move work that might be done in a clinic out to the community or even to the home. Change the providers from doctors to nurses, from nurses to community health workers, from community health workers to self-care. The second was to fix the fragmentation approach across health sectors, so improve communication and coordination. And the third was really at the level of the consumer or the patient to drive health-seeking behavior and thus reduce utilization of traditional healthcare services. But we know that this is really hard to do, even though they're simple concepts, and in fact requires financial support, significant leadership buy-in, as well as buy-in from a staff perspective to make it feasible. And a lot of this has to be customized to local context. So what we've taken away from all of this is that there's a lot of great work being done, that access to more efficient capital markets is a significant opportunity, but also that if we really want to have impact at a health system level, we have to pay attention not just to that care delivery environment, but also to the policies and the payments that form the structure of that health system. And based on this, we've been working closely with colleagues at our Duke Margolis Center for Health Policy to create and refine a framework for what we call accountable care. So how do you hold a group of providers collectively responsible for delivering outcomes to a population for a predefined cost? And we recognize that there has to be an understanding of the local and national health policy environment in which any of these organizations are operating. Secondly, we think that the policy and payment levers that should be leveraged are those that are seen in the middle box here around defining populations and key performance metrics. And we know that as countries in low and middle income contexts are moving toward or aspiring to have universal health coverage, as high actually thrive in a model of value-based healthcare. We've shown that this is feasible, and it's certainly not a U.S. or high-income centric model. And we've done that by showing through case studies in low, middle, and high-income countries that accountable care is a model that can work. And the lessons from this work are, again, quite similar to what we've seen previously in our innovation work, but at a health system level. For innovators or providers, there's significant need to invest in clinical leadership, shared values, and collaboration, especially with communities. There's a need for technology infrastructure that's interoperable and provides longitudinal data. And third, there's a need to shift care to multidisciplinary teams and shifting the sites of care. We see all of these as opportunities for innovators and entrepreneurs to try to disrupt the system. And for payers and policymakers, we see a need to enable access to financial and health data to track performance, to provide a predictable policy pathway that innovators and incumbent health systems can rely on to make change. And finally, to really develop and use evidence along the way to guide reform. So it's more evidence-based and less ideological in its approach. The way that we're starting to put all this together is if you really want to impact a complex health challenge, you have to recognize that there's a lot of different pieces that need to be moved. And the first thing we think that's necessary is actually to understand the problem in a deep way. And whether it's understanding the needs of patients with diabetes in a country like Indonesia, or it's recognizing how to more effectively deal with population health in a place like Singapore. We think that really defining and sourcing this problem is very important. Secondly, to see what innovations are already happening around the world, to try to curate multiple point innovations, whether these are policies or payment systems or delivery innovations or technologies. Thirdly, to try to adapt and integrate them into a cohesive model. Fourth, to then demonstrate that this set of innovations can be deployed in an integrated manner to have impact. And fifth, to do all of this with a lens toward scaling impact. So I will stop here. Thank you for the opportunity to be with you today. I hope this was a useful way to share a little bit of our work. And I'd be happy to open up the floor for questions. Thank you.
We will now ask questions. If any of you have any questions that you would like to ask Krishna, please use the console to type in your questions, and I will raise it to Krishna. Our first question is, you mentioned that there is a mismatch between capital available and capital needs. Can you clarify what are the major failings there, and have you seen any promising innovations or progress which have been made to try to address this?
Sure, thank you. I think that's a great question. A lot of what we continue to see is that there tends to be either friends and family, angel investors, that type of approach that gets a lot of small organizations off the ground. The gap we continue to see are ticket size of deals somewhere between 250,000 up to 2.5 million, especially for global investors working in these diverse markets. We see a lack of efficiency in playing at that ticket size, that most of these organizations are looking to do deals at 2.5 million or 3 million or 5 million and up, which makes sense in terms of their perspective to try to create efficiency in their deal flow. But what we're starting to see is that either organizations are left with a gap in terms of what they really need at that seed or early scaling stage, or they're starting to accept, and investors are starting to make exceptions to invest larger sums of money, and in many cases that's actually leading to bad outcomes. One example that the organization has shared publicly is a secondary hospital chain in India that actually grew too rapidly because they were forced to take on more and more venture capital to keep their growth rate at before they were really ready and had worked out the model, and had grown to almost 20 hospitals, at which point they finally recognized that they had grown too quickly and had to downsize almost half of their hospitals to really fix some of their unit economics and management challenges before scaling again. So what we try to think about in terms of our support is really thinking about not just scalability, but scalability balanced with sustainability, balanced with effectiveness. And so I think there are starting to be more organizations looking at this, but so one other point I'll make on this is also in terms of those capital markets, a lot of what people are looking for are from the impact investment world is below market rate debt, especially in many of these economies where the market rates for debt financing, especially from local banks, can be quite high and can make the business models hard to sustain.
Thank you, Krishna. Our next question is from Sanya Chavla. Her question is, how can we encourage collaboration between diverse funders, that is public capital, grant funds, and impact capital, so that the funding is more structured and impactful?
Thank you. Also a great question. I think we are also starting to see more in this lens. Some of the work that we've done with a partner called Investor Circle that's based in the U.S. but has been a partner to us for 5 years in thinking about growing the impact investment space has been, one, just to get different investors around the table to talk to each other, which doesn't always happen, especially between local and global portfolios. Through Investor Circle, we've been part of something they've done called they've created an advisory board for global health impact investors, and they've now created an interest group that's an open platform that holds webinars that allows people to work together and actually speak with each other. So we're starting to see the communication gaps being filled. We're starting to see more flexible approaches from some global donors, and whether those are bilateral or multilateral donors willing to put capital into different, more flexible mechanisms. So, and we're starting to see more deals that actually bring a local investor and a global investor together that recognize that they have global and local complementary capabilities that are both really important to make sound investment decisions and also to help support that portfolio company over time.
Great. Thank you, Krishna. Our next question is from Matt, who's from JPAL. Matt asks, you talked about building up the evidence base for these solutions. These organizations that you focused on, how many of them have actually evaluated their programs, and what methods have they used?
Yeah, thank you, Matt. I think that's a great question, and I know that JPAL is doing fantastic work in this space, which we should build on. I think the state of evidence is woefully inadequate across the health sector, almost in every geography. There are very, very few traditional approaches like randomized clinical trials evaluating the impact of specific interventions, largely because it's an ineffective approach in these types of contexts where business models are changing on the fly, and to do a multi-year static project is very expensive and doesn't really answer the questions that are at the heart of this field. One of the things that we've tried to do is to create more tools that blend the academic rigor that we think is required with the practical approach of what's feasible. And we've done that through a partnership with our Duke Global Health Institute Evidence Lab, and they've released recently online a set of evidence tools that are aimed at practitioners and innovators in the field to better understand what types of questions they may be asked in terms of evidence, and also thinking about what type of evaluation they can be doing internally and externally to try to be responsive to different evaluation needs. And I mentioned yesterday that Imperial College London has just launched a new report that provides their, albeit quality,
Krishna?
Sorry, I think I lost you again for a second. I unfortunately at the whim of the internet infrastructure in London today.
Krishna, are you there?
Yes, I'm back. Sorry about that.
Okay, so I think we can move to the next question. The next question is that one of the points that you made was that the growth of the MNC activity in this sector is driving a wave of recognition. Aside from raising awareness, what impact do you see the MNCs having on the marketplace? Are they always forces for positive change? And do you see gaps or failings which leave room for small-scale innovators to thrive?
Mm-hmm. Thank you. We work with probably 24 multinational corporations in the pharmaceutical, medical technology, provider, payer spaces, and the work that we do. We certainly see the positive impact they can have, but I don't think it's always positive as with any sector. I think there's positives and negatives that come with their participation and growth. The ways that we've tried to channel the value addition of multinational companies is severalfold. One is to make them more aware of what's happening in terms of innovation in emerging markets so that over time influences their own strategy, whether it's around their corporate strategy or their corporate responsibility strategy. The second is to allow them the space to connect with innovators, with others in this field, so that they feel more comfortable and confident actually entering and growing their enterprises in emerging markets. The third is to find good partners, and in many cases what we're starting to see are large multinational technology companies finding partnerships in small and medium enterprises that are largely service providers in these markets, because I think many of the large technology companies are recognizing that their future is in being part of partnerships that drive solutions, not in being categorized as providers of technology or commodities over time. So we are seeing more partnerships between large technology companies and small providers, and that idea of a private-private partnership is something that we're seeing of significant value to these social enterprises operating in low and middle income countries as part of their own scaling strategies.
Great, thanks, Krishna. The next question is from Sanya. What do you think about social franchising? Does innovations in healthcare come up with toolkits for replicating interventions across diverse contexts?
Sure. We have many organizations in our portfolio that rely on the principles of franchising to drive their business model. One example of that is One Family Health, which is a public-private partnership in Rwanda that's grown to over 100 clinics owned and operated by nurses to provide access to health services and consumer goods in peri-urban and rural Rwanda. We think there's a lot that can come from this type of social franchising business model in driving efficiency, quality, as well as scale. We personally have not done a huge amount of work in trying to create franchising toolkits. We know other organizations have done that, so we're what we see ourselves as doing is really being a catalytic network in this space. So we rely on connecting lots of other organizations and talented individuals to each other. So where we see opportunities, we sometimes directly support organizations that are trying to use social franchising, and other times we connect them to others that may be even more useful than us. One caveat I'll add is that social franchising oftentimes is overhyped as the answer to how to create and scale social enterprises. I think we have to be a bit careful to make sure we're starting with the needs of the problem we're trying to solve, and then understanding the solution, including the business model of the solution. There are certainly times where social franchising is the answer, but there are also many times where it's not.
Great, thanks, Krishna. The next question is from Esther. Her question is, how important is patient education in frugal innovation and implementation of innovation? And what is lacking in patient education?
Sure, thank you. I think that's a critical topic, and I would expand it to include not just patient education, but um, patient engagement and patient empowerment, because we see very little of this happening in many low and middle income countries, and frankly in many high income countries as well. Uh, if we step back from healthcare and really think about health, we know that healthcare is maybe 20% of what influences overall health, that it also has to do with the environment in which you live in terms of access um, to education services, to safety, to lots of other things that are the social determinants or drivers of health. And one of the things that's important for health is the empowerment of the individual as a consumer or as a patient to understand and make health decisions. So I think there is a space for education in terms of promoting health literacy. There's a space for empowerment, and we're seeing entrepreneurial opportunities in each of these spaces. We're seeing organizations like Wiser Care, that's based in the U.S., that's developed technology platforms to support shared decision making, so that patients, when they get a diagnosis of cancer, for example, are more educated without having to rely on a single interaction with a physician. They can take their time. They have a platform by which people are asked about their values, and that helps to better align treatment options with the values and preferences of the patient, and not necessarily just the advice of a single doctor. We see health education companies coming up both to engage providers but also to engage patients more effectively. Bodhi Health Education is an organization operating in India under that model that's continued to scale over time. I do think education, empowerment, engagement is very important and at the heart of what we want to see in terms of our communities to improve health.
Great. Thank you, Krishna. The next question is from Shruti Mehta. How can we encourage more youth to develop startups in the healthcare sectors? Being a part of the youth initiative at the Asian Development Bank, we have noticed that youth are not easily attracted to careers in this sector as compared to fintech, clean technology, and tourism.
Yeah, thank you. That's also a great question. I'll provide my perspective with the caveat that I'm certainly not an expert in this space. I think a lot of this is around helping youth understand what the opportunities are, and what better way to have impact than improve the health and the lives of their local communities. I think that's a very powerful message that can be sent. I think there is oftentimes more difficulty in the health sector because it's in many cases largely driven by the public sector. It's a very highly regulated industry, which can make it a larger barrier to entry. So I think everything we can do to showcase the potential for entrepreneurship will be useful. And I think that starts with education at a young age, and also helping people recognize that that the challenges the health sector faces in their own local communities are not ones that have to be taken for granted, but ones really that can be addressed through innovation and entrepreneurship.
Thanks, Krishna. We'll take the last question for today. This is from Catherine James. During the course of your study, did you find national governments to be receptive of supporting innovative models in their national healthcare programs, which could be a game changer for scale-up countries like India? Any instances of innovations influencing public health funding?
Sure, and thank you, Catherine. I think that's also a great question. And we recognize that our lens in our work has largely been on private sector innovation, but in almost no country can a private sector innovation reach scale without some collaboration or partnership with the public sector, whether that's with the public sector as a policymaker, regulator, payer, or oftentimes even as a provider and scaling partner. So we see a huge gap in especially the ability of small and medium enterprises in their ability to, forget influence, just engage the public sector, get a seat at the table. So one of the things that we've been doing in our work is to try to
Krishna? Krishna, are you still there?
Yep. Yeah, sorry. Unfortunately, I'm, as I said before, a bit stuck with the internet infrastructure in London today. That I was just saying we see a huge gap that we've been trying to fill in getting especially local social enterprises, the small and medium enterprises together with local and national policymakers to have conversations around how the public and private sectors engage. I think there are models where we've seen this be successful. One of them is what I pointed out earlier in One Family Health, where the Ministry of Health of Rwanda is at the table with a social enterprise, with GSK that provided some early capital, with EcoBank that's providing the capital to launch social franchising. I think India is particularly difficult given the fragmentation, and many innovators have in fact tried to create private sector only approaches, and once they're scaled from a stronger position, then try to influence things with state governments especially. So we see a huge opportunity in India to work with state governments, many of whom are quite open to public-private partnerships to try to have impact in health, and that's in fact one of the new initiatives we'll be taking on over the coming months.
Thank you everyone for this very interesting session. Thank you very much, Krishna. We will post the webinar recording on our website by next week. Please look out for that. Also, AVPN is holding the AVPN India Summit 2017 focused on investing for impact in education on 14th of September. Member registrations and early bird tickets are now available. Good day, everyone.
Thank you all.